Alright, so today's lecture is going to be over the second part of colon disorders. If you're watching this, you should have already watched the colon disorders part 1, which included irritable bowel syndrome, diverticulitis and diverticulosis, and acute mesenteric ischemia or ischemic bowel disease. In this lecture, we have our instructional objectives, and we're going to be covering inflammatory bowel disease, which is different than irritable bowel syndrome. We're also going to be covering toxic megacolon, polyps, and neoplasms. So let's jump right in. We do have quite a few slides to cover, and this is going to be kind of a marathon type of lecture, but I'm going to try my best to get us through this. So inflammatory bowel disease, or IBD, is an umbrella term for two other diseases called Crohn's disease and ulcerative colitis. Those are the two sister diseases that fall under the IBD diagnosis. Before we get into the specifics of each of those, we're going to talk really briefly about IBD in general. So the term IBD includes Crohn's disease. Notice they put Crohn instead of Crohn's. That's kind of a progressive way of describing Crohn's disease. If you hear me say Crohn's or Crohn, it's just out of habit, I've always called it Crohn's disease, and either way is fine. We're trying to move away from the possessive forms of diseases. Anyway, Crohn's disease is a chronic recurrent disease, and this is by transmural inflammation involving the GI tract from mouth to anus. Ulcerative colitis, on the other hand, is also chronic. It's recurrent and causes diffuse mucosal inflammation, so not transmural, and it only involves the colon and rectum. Invariably involves the rectum and may extend proximally, so it either goes rectum, rectum proximal transverse, but it's always continuous, and it can actually be the entire colon. Now, in the United States, there's approximately 1.6 million people with IBD. That's a lot. It's not terribly uncommon to see this. Now, there is a familiar empiric risk. We see it a lot in the Jewish population. And I'm not talking about the religion Jewish population. I'm talking about Eastern European Jews and Ashkenazi Jews. More common in Caucasians, and we tend to see it kind of in the 15 to 35. I tend to see it more in 20s to 30s, but this is kind of a more conservative view of that. So we're going to jump right in. We're going to talk about Crohn's disease first. Now, in Crohn's disease, we talk about regional enteritis. We said it is from mouth to anus, so you can have lesions anywhere from the mouth all the way down to the anus. It is chronic and it is transmural. So I'm sure in patho you're going to cover what that means. But essentially it means it goes through all the layers of the GI tract. And it most commonly affects the terminal ileum. So we know there's three parts in anatomy, three parts of the small bowel. We have the duodenum, the jejunum, and the ileum. And at the terminal ileum, where it terminates into the cecum, that is the most common site of Crohn's disease. Now, there are different major patterns of disease. We're going to talk about small bowel involvement, 1/3 exclusively ileitis, so just in the ileum. That's 80% of the disease. Okay. Disease in the terminal ileum and cecum. There's also disease confined just to the small intestine, and disease confined to the colon is only 20%. So it's not nearly as common in the colon as it is in the small intestine. And the most common spot, again, is the terminal ileum. It can, other parts of the GI tract, like we said, mouth to anus, it can be involved, but it's a very small minority that are involved. And it can be anywhere from the mouth with abscess ulcers, the stomach, esophagus, and working its way down to the small intestine, all the way down to the colon and back. Cigarette smoking is strongly associated with Crohn's disease, and anytime you have a patient that has Crohn's disease, you should highly recommend that they stop smoking. So again, we're not covering patho per se, but we want to mention it. Terminal ileum is the hallmark location again. Other sites can be involved. It often has these skip lesions, meaning like you can have a little patch here, and then it skips a little while, and there's a little patch of inflammation here, a little patch here, and so on. It's not continuous, it's discontinuous. Now, because it is transmural, meaning it goes through all the different layers of the bowel, it can fistulate, meaning that it can be an abnormal connection from the bowel to another part of the bowel, from the bowel to the skin, or from the bowel to the bladder even. Okay, so that's one common finding, or not, maybe not common, but it's associated with Crohn's disease. You can also get strictures because of the chronic inflammation. Remember, this is a chronic inflammatory disease, and we think of it as autoimmune. The body kind of attacks itself. Now, this inflammatory disease, as you can tell, you get this chronic inflammation all over the place, and inflammation can lead to stricturing. Stricturing are when things kind of clamp down and scar down. It also has the presence, or can have the presence, of non-caseating granulomas. You can also get some fat creeping, and I'll show you a picture of that. It's essentially, you'll have normal fat in and around the bowel, but the fat tends to kind of envelope or surround the bowel more than it normally does. I love these drawings. I don't know why, but they tend to give me a good picture of things, so you might want to take a look at this. We're going to look at the clinical features of Crohn's disease. So patients with CD or Crohn's disease usually have symptoms for a long time or a few years before they're diagnosed, and it's actually really difficult to diagnose Crohn's disease because the symptoms are quite vague and they can be hard to diagnose. Otherwise, some patients may present acutely, like having an acute flare, and that's how their first presentation happens. Remember, it's chronic, and it can have an indolent course, and it's pretty unpredictable. It has these flares and remissions. That the cardinal symptoms, so the ones that we tend to see most often, are abdominal pain, diarrhea. It's usually frequent bouts of diarrhea, even nocturnal diarrhea, and that's with or without bleeding, and then fatigue and weight loss. So the abdominal pain, patients generally describe it as this crampy abdominal pain. It doesn't always have like a specific spot. However, if you have disease in the terminal ileum itself, then it tends to be located more in the right lower quadrant area. Because it's transmural, you get these fibrotic strictures, and so sometimes patients might present with a bowel obstruction because of the stricturing. It lessens the lumen inside the small bowel, making it more difficult for things to pass. It's less common to cause colonic, usually small bowel obstructions. And then patients can also have early signs of obstruction, so fewer bowel movements, but not necessarily complete obstruction. Now, the diarrhea is a really common presentation, and this diarrhea can kind of fluctuate over time. You get these flares and remissions. So usually in the history, it's just this intermittent diarrhea, not necessarily with gross blood, but sometimes it can have a little bit of blood in it. And usually it's combined with other extra intestinal features like skin, eye, joint problems. So you have to put all the pieces together to be able to diagnose it. Like we said, fatigue is common. Weight loss is common because patients usually have a decreased oral intake because they feel better when they don't eat. They can also have malabsorption, which can cause weight loss and decrease in vitamins and nutrients and things. Fever is less common. Maybe in the acute inflammatory process, you can have a little bit of fever, or if the patient has developed kind of an intra-abdominal abscess. The features of transmural, since it goes through all those layers, these patients can get fistulas, they can get abscesses and phlegmons, and they can get perianal disease, which is in contrast to ulcerative colitis. The extraintestinal manifestations, there's a lot of different extraintestinal manifestations. We're going to look at the next slide that's going to tell us a little bit about them, and they affect kind of the whole body. So this is a really long chart from Up to Date. These are all the different things, extraintestinal manifestations of inflammatory bowel disease. Here's also a more a more crunched down version, but things we tend to see are this eye involvement, so episcleritis or uveitis in the eye. Patients with Crohn's disease can also get kidney stones, fistulas to the kidney or bladder. Skin, they can get one of two different kinds of skin conditions. One is erythema nodosum, which we have talked about before, but are these kind of reddish nodules, usually on the shins and the forearm area or elbow areas. They can also get this pyoderma gangrenosum, which are these, looks like an ulceration on the skin. They have trouble with circulation. They have problems with their joints. Can also get gallstones and primary sclerosing cholangitis. They can get fatty livers, and they can have, like we said, mouth ulcers or stomatitis. So this is just some of them. You can see that the list is a lot longer. Those are some of the main ones that we think about. So in physical exam is not the most helpful with Crohn's disease. Like we said, it can be kind of hard to diagnose. We have to put the pieces together. So it could be a normal physical exam. It might show some kind of non-specific signs like weight loss. You can also have these perianal skin tags, which are evidence of perianal disease and possibly fistulation, like sinus tracts. And sometimes they'll have some abdominal tenderness. And like we said, if there's a terminal ileum that's involved, it's usually the right lower quadrant. So the diagnostic evaluation, the goals are essentially to, first of all, suspect that the patient could have Crohn's disease. And there's a lot of things that we do that don't necessarily diagnose Crohn's, but they help us rule out other conditions. We have to establish the diagnosis and then determine the severity of the disease, which will help us determine how we're going to treat the patient. So when we test patients, let's go back. When we test patients, it usually includes the typical workup of laboratory studies, and this includes blood tests and stool studies, plus or minus some small bowel imaging, usually an MRE, and a colonoscopy, which in most cases is the definitive diagnostic study. They usually actually do an ileocolonoscopy where they go through the entire colon, right? Go up and into the colon. And right here at the cecum, this is the cecum, they do a push through. They go in and they peek inside the terminal ileum, and they take biopsies from there. All right, so laboratory studies, what are we talking about when we talk about lab studies? It's complementary. It's not the definitive way to diagnose it. There's not one single lab test that can say, aha, that's what we have here. But it is helpful to put those pieces together like we mentioned before. Now, as far as blood tests are concerned, we like to get a CBC. This looks for increased white blood cell count, or it can be also decreased hemoglobin and hematocrit, right, for chronic anemia or blood loss. Chemistry, we're looking at electrolytes, renal function, blood glucose, and then we're also looking at kind of studies to look for iron deficiency anemia, like serum iron, vitamins, because remember they have malnutrition, so the malnutrition can cause them to be deficient in certain vitamins. We also look at non-specific inflammatory markers like CRPs and ESRs. None of this gives us the answer we're looking for. It just helps us kind of see the broad, bigger picture and look for other things that could be going on. Now, stool studies, because Crohn's disease is a chronic disease, usually the patient takes a while to come in, but especially in an acute case or someone that's never been worked up, we definitely want to work up testing for enteric pathogens. So we're looking for infections, right? So ovum parasites, stool cultures, C. diff toxins, maybe Giardia assays, right? So we're looking for all the different infectious type causes of diarrhea. We also look for stool inflammatory markers like fecal calprotectin or lactoferrin, and these are not necessarily used routinely for Crohn's disease, but usually when we send these stool studies, we send it for everything. Okay. Now, continuing on, we said another major thing that we do is endoscopy. Now, I would say colonoscopy or ileocolonoscopy is the best definitive test. The biopsies that we get from them, we send to the pathologist, they are what generally confirms the suspected Crohn's disease. When we look in there, we're looking in camera, we tend to see these focal ulcerations. They're in a skip pattern. So there's a patch here, goes a little further, a patch there, and there's a normal appearing mucosa in between. And then we also see this hallmark cobblestone appearance, and I have this slide here to kind of show us that. So cobblestones are like this non-paved roads or sidewalks that have these stones that kind of don't follow any specific pattern. And so you can see here, this is kind of a cobblestone appearance. This is obviously colon that's been removed, or small bowel that's been removed. But you can see here, this is kind of a cobblestone appearance, and they like to mention that because it's pathognomonic for Crohn's disease. Usually, if we have problems, because we know that Crohn's disease can be from mouth to anus, these patients generally, when they get put under for the colonoscopy, tend to get an upper endoscopy as well, especially if they have upper GI symptoms. You can get ulcerations, inflammation, etc. Sometimes let's imagine this. We said we can examine, this is a person, okay? We said we can examine the upper GI system with an endoscopy. We can get all the way to the stomach, right? And the first part of the duodenum. But then you have all this small bowel. And then we said we can go from the other end up and through the intestine, right? Through the colonoscopy, right? And maybe into the terminal ileum. But what about all this other small bowel, right? There's a lot of small bowel that we can't look at, and some patients can have disease just limited to the small bowel. So for that, we can do what's called a video capsule endoscopy, where we can have patients swallow, looks like a pill, it's a camera, and it can take video as it passes through. The only problem with this is if you expect that the patient has a stricture, like they have advanced disease, there's a chance that this video capsule endoscopy, or the little camera in the pill, might get stuck and not be able to pass through a stricture, and then we have to do surgery to remove it. What we tend to do more often, instead of doing the pill cam, is small bowel imaging. Now, imaging has gotten much more sophisticated, and we can use it as part of the diagnostic evaluation, especially to evaluate the small bowel that is not accessible by EGD or by colonoscopy. And the recommended study of choice is going to be an MRE, or a magnetic resonance with small bowel interrography, and that's an MRI, or and then they also have CTE, but this is definitely more radiation, and it's comparable, but if we can, we try to get the MRE. And that's what the MRE looks like. You can see the inflammation here. You can see the inflammation, and it's not all over, it's just in certain places, and that's diagnostic of Crohn's disease. All right, so complications. Lots of things can go wrong when you have chronic disease, especially something that is transmural, goes through the entire bowel, or can, and we can have all sorts of complications and problems because of it. Now, we already mentioned fistulations. The fistulations can be from one part of the intestine to the other. We can be from the intestine to the bladder. It can be from the intestine to the vagina, and it can be from the intestine to the skin. And so if you can imagine, this is, you can have stool, the bladder, you can have peeing of air and stool. You can have leakage of that same kind of material into the vagina. You can also have leakage through these little skin tracts, perianal disease. So anal rectal disease, like we said, in 30% of the patients, fissures, abscesses, perianal fistulas. Small bowel obstructions, like we mentioned, patients get chronic stricturing and scarring from the chronic inflammation, which narrows the lumen of the small bowel, which can cause the small bowel obstruction that we talked about in other lectures. Now, there is an increased risk of colon and small bowel tumors. It is less common than ulcerative colitis, however, but there is increased malignancy. Patients also get malabsorption because there's chronic inflammation in the small bowel where all these nutrients are absorbed, and so you get vitamin B12, bile acid problems. Also, cholelithiasis is more common, so gallstones, because of decreased bile acid absorption, like we mentioned here. You can also get kidney stones. Aphthous ulcers, like we mentioned, mouth to anus. Toxic megacolon is less common in Crohn's disease, but it can be seen, and we will look at that later on in this lecture. Patients, because they have malabsorption, decreased diet, and they can have growth retardation. They don't grow as expected. And then these patients have chronic pain, chronic issues. So a lot of these patients, if they're allowed, become addicted to narcotic medication. All right, so how do we treat it? Before we get into the treatment, I just want to mention that the treatment for Crohn's disease and for ulcerative colitis can be quite complicated. Now, I'm going to do my best to try to simplify it for us, and I don't expect you to know every single treatment and alternative and this and that and all that. We need to know the gist of it for our purposes here. So I'm going to try my best to keep this simple, but it is complicated, so I'm warning you ahead of time. You might have to review this several times before it sticks. This is a chronic, lifelong illness, okay? It has exacerbations and remissions, so there is not one specific therapy. Therapy is directed towards symptomatic improvement of disease, and so these patients, they can kind of wax and wane. They get better. They have a better quality of life. We reduce disease progression and complications. It's essentially what we're trying to do here. And most patients, have this moderate to severe disease. However, some will have some more mild to intermittent disease. So there are some risk factors for developing a more aggressive disease course, young age at disease onset, early need for corticosteroids, evidence of perianal disease, stricturing, or upper GI involvement. Those put these patients more in the moderate to severe risk category. Laboratory markers of severe inflammation, low albumin, low hemoglobin, or high CRP, those will put you more, again, into this moderate to severe. And then endoscopic findings of deep ulcerations will also kind of put you more in this moderate to severe disease. So I guess if we're talking about moderate to severe versus mild to intermittent, the choice of therapy really depends on the disease severity, the patient age, comorbidities, and the patient preference, because there are several different methods for treatment, and there's no one size fits all. We want to have sustained clinical remission and have mucosal healing. That is our goal, right? It's not always achieved. Some patients just cannot find remission. They kind of have this waxing and waning, exacerbations and remissions. Early introduction of biologic therapy should be considered to moderate to severe disease, which we will talk about. These are some of the newer medications, the biologics, especially with those with these risk factors for a more progressive course. And then all patients with Crohn's disease should be counseled to discontinue cigarette smoking. It does make it worse. All right, so there are two general approaches to the treatment of Crohn's disease. If you don't remember anything from this lecture in regard to treatment of Crohn's disease, remember this, okay? We have two major approaches. One is the step-up therapy, meaning that we start with the most minimum or less potent medication, and we work our way up, increasing more potent medication up until we get remission. So it's usually what we do for more mild cases of Crohn's disease. We usually start with the step up, where we start with the least potent medications and kind of work our way up till we get where we need to be. Now then the opposite would be top down, meaning that we start with the most potent therapies such as biologics, and we work our way down to where we get remission. This is usually in moderate to severe disease, right? So we use biologics, immunomodulators, and steroids. So the up-to-date favors step-up therapy, again, in patients with low risk and mild Crohn's disease, which is what we mentioned before. And we can progress up from that to find a comfortable spot where we can limit, where we can get the patient in remission and limit exacerbations. High-risk patients, however, and moderate to severe Crohn's disease should be done from a top-down approach, which makes sense, right? So we want to get those medicines in quickly. We want to get them more rapidly to this clinical remission to get them off steroids. It's difficult, right? This is a case-by-case basis. There's not one size fits all, so it's not likely that there'll be some controlled trials that'll ever be able to give this every clinical circumstance algorithm. We have to also consider cost of therapy, patient compliance, susceptibility to drug toxicities. Those are all also factors that we have to consider when prescribing these medications. So let's go through the different types of medications that we use. I know you'll probably cover these more in depth in Pharm. Then once we're familiar with the different medications, then we'll talk more about kind of the step-by-step approach to using these medications. So there is a medication called sulfasalazine, a group of medications, or a 5-ASA. These are very useful if the colon is involved. So remember we said in most cases of Crohn's disease, it typically involves the small bowel, not the colon. So it's not as commonly used in Crohn's disease as it is in ulcerative colitis. It is more commonly used in ulcerative colitis, but it can be used. There's also antibiotics. It's not often used anymore, usually just treating acute exacerbations with, say, abscess formation. There are systemic corticosteroids. However, we try not to keep patients on systemic corticosteroids because of the high profile side effects. So we use them for acute exacerbations in these cases. There's also immunosuppressants, so like azathioprine, and usually use these in conjunction with steroids if they're not improving. We also have the newer medications, the anti-TNF or biologics as we call them. Those are like the infliximabs and the adalimumabs. These are recommended first line for moderate to severe Crohn's disease. There's also some biosimilars, which I'm sure you'll cover in Pharm, which are similar to biologics. We also have some other medications which are more symptom-based, which are bile acid sequestrants, which help decrease diarrhea, especially in those that can't absorb bile acids, and just general antidiarrheal agents like loperamide, but these are not a good choice for these type of patients as they may cause ileus. These patients occasionally might need surgery, and it says eventually required in most patients, but it's usually reserved for complications of Crohn's disease. So patients that develop like fistulations or have a really inflamed segment of bowel that is just not improving with medications, you can't get remission. The only thing is, it's not like you can just take the whole small bowel out. You can't do that. So you do get disease recurrence even after surgery. So indications, like we said, for surgery are going to be small bowel obstructions, fistulas, perforation, abscesses, and things like that. You also have to consider, when you consider treatment as a whole, nutritional supplementation as needed depending on the patient. So don't get overwhelmed by this. This is essentially a chart that kind of takes you through the mild to moderate Crohn's and the moderate to severe Crohn's. So they're kind of two separate kind of algorithms to follow. And it depends kind of where the disease is and how bad it is. So ileitis, right-sided colitis, you're going to start with budesonide, which is a steroid. And if you can achieve remission, great. If you can achieve it, you'll use it for about 3 months, and then you can decide whether or not to continue on a different medication. If you cannot get remission with budesonide for this, you're going to jump over to this algorithm. Now, if you have colonic disease, so in the colon, you're going to use the mesalamine, the 5-ASA, and then if it's responsive to treatment, yes, you continue using it. If you can hit remission, you just continue using it. If you can't, you want to consider immunosuppression. If you're not responsive to treatment, you can try antibiotics. If they're not responsive to that, you can try this algorithm. So I know it's kind of complicated. I don't expect you to know every single pathway, but it is nice to kind of see it as a whole. If they have moderate to severe disease, remember, we're going to probably start as more of a top-down approach. So systemic corticosteroids, sort of short-term systemic corticosteroids, and AZA. If you can get remission with that, then you can kind of do maintenance therapy. If you cannot hit remission with that, then you could start the anti-TNFs or the biologics. And if you can hit remission with that, then you consider the maintenance for, and then if you can't hit remission, considering biological and surgery. Okay. Here's Osmosis's version of those two charts. Step up and step down therapy. So again, mild Crohn's disease, it has a low risk. And remember, on this chart, you can see the low risk profiles. These are lower risk. Okay. These are the patients that would fit in this chart right here. Okay. So you're going to start with oral budesonide, 12 weeks or 3 months, right? 3 months. This is ideal if you have ileal involvement. You can also consider oral prednisone or a 5-ASA like we mentioned. If you have diffuse colitis or left colonic involvement, you can do prednisone. You can also use, if it's left colitis, can use oral sulfasalazine. And then here's what to use when in remission. Step down therapy, you're going to start with probably a biologic or immunomodulator. If they're older than 60 years old, you're going to want to use infliximab, which is not necessarily something I need you to remember for right now. You're also going to use short-term glucocorticoids like prednisone and budesonide, and then transition over to remission maintenance therapy. So what's the prognosis for Crohn's disease? Symptoms are chronic, they're intermittent, and from patient to patient, it can vary a whole lot. Some patients have continuous progressive courses of active disease, and some patients have prolonged remissions, right? So it's just trying to find the right concoction to help keep these patients in remission, and it can be challenging to do so. So I certainly recommend that if you're working in primary care and have a patient with Crohn's disease, you should definitely refer them to gastroenterology, and these patients should be managed by a gastroenterologist. Risk factors for progressive disease, so disease that is progressive, age less than 40, using cigarettes. This is the third time I mentioned, tell them to quit smoking. If you have perianal or rectal involvement, you have higher risk for progressive disease as well as glucocorticoid requiring disease if it doesn't get better. Like we said, many patients ultimately require surgery, although it's not curative. Because we have better medications nowadays, we have lower rates of surgical resection. However, when you have bowel obstructions, abscesses, perforations, and refractory disease, it's inevitable. We mentioned again in the complications slide that colorectal cancer can be increased in Crohn's disease. And it says, at least here in my source, that it's probably comparable to ulcerative colitis. However, I've always known ulcerative colitis to be more risky of colorectal cancer. Patients have an overall mortality, a little bit higher mortality than the general population. So Crohn's disease patients, chronic, it can be difficult to treat. Trying to find that the right amount of medication to get them into remission and keep them there. talk about ulcerative colitis. Ulcerative colitis, remember, it falls under the same umbrella as Crohn's disease, but it is quite different in presentation. Now, in some cases, Crohn's and ulcerative colitis can be very difficult to distinguish from history and physical exam alone, and that is why the other studies are so important in diagnosis. So it's chronic, idiopathic, generally thought as autoimmune inflammatory disease of the colon or rectal mucosa. Again, it can occur at any age. We usually think of it as kind of 20s to 30s, but it can start as young as children and teenagers. Ulcerative colitis always involves the rectum, and it can involve the colon. It always starts there and works its way up if it does, right? It starts in the colon, in the rectal area, in the colon. There are some statistics. So the rectosigmoid region alone, so proctosigmoiditis, is a fourth of the patients. Rectum and left colon will be half the patients. Rectum, left colon, and right colon, a fourth of the patients. This is called extensive colitis. And then pancolitis is everything, including the cecum. This is obviously the worst case. In patients with distal colitis, the disease progression with time is more extensive in involvement in 25%. So you can also, we think of ulcerative colitis as a primary disease of the colon or rectum, but you can actually get a little bit of what they call backwash ileitis, where you get some disease that kind of backwashes into the ileum, into the terminal ileum. But it's not as common. It's only 10% of the cases. Course is unpredictable, similar to Crohn's disease, very variable, and most patients kind of characterized by periodic exacerbations and remissions. Less than 5% of patients have an initial attack without any recurrence. So it is very often a disease of waxing and waning. So because this is not pathophys, but it's important to kind of understand the major differences between UC and CD. So uninterrupted involvement, this is continuous. So it starts from the rectum and it can work its way up the colon. It has no skip lesion. Doesn't work. It doesn't do like a little bit, skip this portion and then go here and then skip and then go here. It's continuous. It is not transmural. It is limited to the mucosa and submucosa, so you don't see the same complications with ulcerative colitis that you do with Crohn's disease, including the abscesses and the fistulations. Okay, you do see these crypt abscesses, which is a little different than frank abscesses from fistulations. It's more common in smokers. More common in non-smokers and former smokers, which is kind of strange. The severity may be lower in active smokers and worsens when patients stop smoking. I don't know why this is. It'd be interesting to look it up. If you know the answer, please reach out to me because I'm curious about that. An appendectomy before the age of 20 years is associated with reduced risk of developing ulcerative colitis. Who knows why that's the case too. So just like Crohn's disease, there is a wide range of presentations, but generally speaking, on vignettes and in the clinic, the major hallmark symptom of ulcerative colitis is going to be hematochezia, so bloody diarrhea. And patients with UC may have non-bloody diarrhea at first, but it almost always progresses to bloody diarrhea. And here is a perfect picture of this like bloody diarrhea in the commode. And if you click here on this link, it'll take you to a blog called the Poop Diaries, and it talks about kind of the day in the life or days in the life of the patient with ulcerative colitis. Patients also have abdominal pain. So remember, in Crohn's disease, it's more diffuse diarrhea and some abdominal pain with weight loss and fatigue, whereas ulcerative colitis is more hematochezia with abdominal pain. They tend to have multiple bowel movements, frequent but small, and they get this tenesmus. So remember I mentioned tenesmus before. It's like the bowel is trying to get rid of stool, but there's no stool there, and so it's kind of like dry heaving, right? You're just kind of pushing or feeling the urge to push out stool when there's no stool present. It can be very uncomfortable for patients. They can also get incontinence, fever, fatigue, anorexia, weight loss. These are more severe cases. These are systemic type symptoms. And then just like Crohn's, we have extraintestinal manifestations, including some of the same things like jaundice, uveitis, arthritis, and skin lesions. The onset of symptoms is usually more gradual and progressive. And sometimes you might have this kind of self-limited episode of rectal bleeding, and then you get it again and it's more progressive from there. So you have to really get a good history on these patients. Physical exam, just like Crohn's, pretty much normal, especially in mild disease. Moderate to severe might have abdominal tenderness, maybe even some fever, hypotension, tachycardia, and pallor from the blood loss. Rectal exam, which you should do in all patients with an abdominal pain. And of course, if you're having hematochezia, you would like to get that. It's going to show an evidence of blood. Patients that have this prolonged diarrhea can also have muscle wasting and weight loss and malnutrition as well. So similar to Crohn's disease, we have to assess disease severity in order to decide how to treat the patient. So we look at different criteria to kind of place them in this mild, moderate, or severe classification. We look at these different things. So we're looking at stool frequency. We're looking at their pulse, their hematocrit, weight loss, temperature, ESR, and albumin. And we use all those parameters to try to classify them as mild, moderate, or severe. How do we evaluate these patients? The evaluation, again, you have to suspect it first. We want to exclude other causes of colitis and establish UC. And the diagnosis is usually made by colonoscopy and biopsy. We're going to have chronic diarrhea, more than 4 weeks, evidence of active inflammation on endoscopy, and chronic changes on the biopsy. You also have to exclude other things, other causes of colitis by history, including lab studies and biopsies, right? So the stool studies are similar to Crohn's disease. We have C. diff toxin, stool cultures looking for these bugs, Giardia stool antigen, OMP, to rule out essentially infectious diarrhea. You also want to look at fecal leukocytes, although it is pretty nonspecific. Fecal calprotectin is pretty nonspecific as well, but we tend to get kind of a batch stool study when we have these patients. Blood work, so CBC, electrolytes, albumin, markers like ESR and CRP. Also, because this tends to affect the rectum, if we're unsure, we might want to get STD testing, especially in patients who are men that have sex with men or that have severe rectal symptoms, and that is to rule out infection, sexually transmitted infection in the rectum. Endoscopy and biopsy are going to help you make this diagnosis. You're going to get biopsies, and these are going to be helping establish chronicity of inflammation as well as excluding these other causes of colitis. Now, if you have a patient that's acutely hospitalized for an acute episode of UC or suspected UC, you should avoid colonoscopy because those patients have the potential to precipitate toxic megacolon, which you certainly want to stay away from. And in this case, we can elect to do a flex sig to kind of look at the proximal colon. So on endoscopy, what do we see? Well, we see ulcers, ulcerations, loss of vascular markings, erythematous, friable, so it's easily bleeding. You barely touch it and it just kind of bleeds. Can see these pseudopolyps as well because the mucosal layer gets kind of sloughed off, and and not necessarily all of it. So the areas that kind of get left, they have these little polyps that kind of stick out, which is the remnants of semi-normal tissue where everything else has been ulcered away from it. So it looks like polyps, but they're not really polyps. On biopsy, I'm sure you'll study this in patho. You tend to see crypt abscesses and things like that. So ulcerative colitis, Usually you'll see a continuous patchy inflammation. However, in patients who have been treated, you can also see like kind of this patchiness rather than continuous because of the treatment. Imaging with plain radiographs or CT is done in patients with severe colitis to look for severe colonic dilation like toxic megacolon. And barioenemas, we used to use them a lot. We don't really use them anymore for diagnosis purposes. So complications, there are some similar complications to Crohn's disease. We have anemia, hemorrhage, electrolyte, dehydration, strictures, both benign and malignant. Colon cancer, there's a much higher risk associated with the increased duration and extent of colitis. And then they also can get sclerosing cholangitis, which we'll talk about in the gallbladder pancreas lecture. You can also get cancer of the gallbladder or the bile duct, because of UC. Toxic megacolon we're going to talk about specifically. It only affects about 5% of patients, but it is so striking when we look at it that you're going to want to always consider that in these patients. And similar as before, you get the same kind of growth retardation, narcotic abuse, and psychosocial issues because of the chronicity and disabling nature of the disease. All right, so treatment. 3 main objectives of treatment. We want to stop the acute attack, we want to achieve remission, and we want to prevent future attacks, which makes total sense, right? It depends. So depending on what we start with ulcerative colitis is going to depend on the extent of the colon involvement. And that's what we talked about earlier in that chart. We had the mild, moderate, and severe. So we're going to look at those signs of inflammation, the number of episodes of diarrhea, the increased risk for hospitalization or surgery, and kind of treat them accordingly. So as far as medical treatment, it's the same players that we saw essentially in Crohn's disease. So we have systemic corticosteroids for acute exacerbations. Because sulfasalazine is better in the colon and ulcerative colitis is exclusively in the rectum and colon, we tend to use 5-ASAs more often as the mainstay of treatment. And remission rates can be as high as 93%, so that's good. Okay. Immunosuppressive agents can help with refractory disease, not as effective for acute attacks. Now let's go kind of step by step here. So in mild to moderate distal colitis, we usually start with a topical mesalamine. Remember, we can kind of reach this area, so we tend to use suppositories a lot, especially in milder disease. And that helps avoid having to administer these medications systemically and avoid some side effects. Now, this does require that you're putting a suppository up your bottom on a daily basis, which is not necessarily everyone's cup of tea. So there are patients that might decline to do this, and if that's the case, then we tend to go with an oral 5-ASA. Now, topical corticosteroids, we can also do topical corticosteroids via enemas or foams that can be placed up the anus into the rectum, and that's kind of our second line treatment. They usually a short-term use that we use these for. For patients that don't improve with either of those, we can consider a combination therapy of topical with an oral. We can also use topical corticosteroids, addition of oral prednisone if needed, and systemic corticosteroids, like we said, are just for acute exacerbations. Now, what about mild to moderate colitis? Okay. This is colitis. Remember, this one was distal colitis. Now we're talking about colitis in general. So 5-ASAs tend to be oral and rectal. And most patients improve 4 to 8 weeks. And some patients like to start just with oral and then maybe add topical if it's not adequate. These patients improve, 75% of the patients improve, and remission 20 to 30%. Corticosteroids, so patients who do not improve with the 5-ASA can be added budesonide or prednisone. And if patients are having to use corticosteroid therapy, remember we're trying to minimize the use of corticosteroid therapy. But if they're having to use these for symptomatic relapse over and over again, we might need to step them up to an immunomodulator or a biologic agent. Moderate to severe colitis, systemic corticosteroids is first line to get the patients quickly into remission. We also recommend biologics. Here's the corticosteroids. We can start with prednisone or methylprednisolone. You usually see rapid improvement with these corticosteroids, and we want to use them short term. And we want to do a taper. It's usually a pretty long taper because we're using higher doses, and get them all the way down and placed on a mesalamine. Now, not all patients respond to prednisone, and if that's the case, we need to consider azathioprine or one of the biologic agents. And again, infliximab or vedolizumab are the first-line therapies. Immunomodulators, like we talked about, you can add immunomodulators to the biologics and do kind of a synergistic therapy, and that does increase the likelihood of remission. All right, last but not least, severe fulminant colitis. This is bad. This is about 15% of patients have severe course, and fulminant means everywhere, and they're having multiple episodes of bloody diarrhea. These are the most severe cases. We want to pretty much put them NPO. They'll be admitted to the hospital, and they usually get a CT or plain radiograph to look for the colonic dilatation of toxic megacolon, because toxic megacolon is most common in this severe fulminant colitis. Corticosteroid therapy, we're going to hit them hard. We're going to hit them with IV steroids. We're going to start them on infusions of the biologic agents. Usually give some cyclosporine, especially if they have not improved after 7 to 10 days of corticosteroids. And then in this case, patients with severe disease who do not improve with all of this are usually recommended for surgery. And the good thing about ulcerative colitis, in contrast to Crohn's disease, is surgery can be curative, because we can take out the entire colon, we can do a total colectomy, and that can essentially cure the patient. Now, it doesn't mean that they're not going to have other issues from removing the colon, but it can be cured, quote unquote. Now, if that was a lot of information for you, I did kind of cut and paste these 4 different approaches that I copied from osmosis. We started with one, which was a mild to moderate proctitis or proctoid sigmoiditis, which shows you it's right here. That was the first kind of thing we talked about. And then we talked about the mild to moderate distal colitis or colitis, which is all of the colon. And that's what we talked about treatment. Then we talked about severe, right? And these are kind of the medications. And then acute complications or fulminant ulcerative colitis and how to approach it. This will kind of help you kind of put all those different treatments together. So we said for surgery, unlike Crohn's, it involves a total colectomy. You take out the entire colon. It can be, you use this therapy in a debilitating, refractory, unresponsive treatment. Also, if the patient has toxic megacolon or obstruction, severe hemorrhage or perforation, go ahead and remove the entire colon. And some of these other indications. Essentially, remove the whole colon. You can either do a little pouch or anastomosis, where you connect the ileum to the anal area. And then there's also this total removal of the colon with a permanent ileostomy, where you have a stoma and you have to use bags to collect your stool every day. All right, so we've covered both Crohn's and ulcerative colitis. So this is kind of a wrap up, kind of a let's look at both in contrast to one another, because that's usually kind of what we have to narrow it down to when we're reading vignettes and treating patients. So involvement, again, Crohn's is transmural from mouth to anus, and it's discontinuous. There's skip lesions, okay? And I like to think of that patients like to skip on cobblestones, okay? In contrast to ulcerative colitis, it's just the mucosa and submucosa, and it's continuous. It's not skip lesions. The location, terminal ileum, is most common, and it can involve any part of the GI tract. The ulcerative colitis is confined to colon and rectum, and colectomy is curative. Complications, remember, because this is a transmural process, you get fistulations, abscesses, because the entire wall is involved. You tend to get sclerosing cholangitis, colorectal cancer are more common than in Crohn's disease. And here's some pictures. I know this is more patho for you, but here's that cobblestoning, right? I like to say we skip on cobblestones. And this is that kind of fat creeping or fat wrapping I was talking about at the beginning. This is ulcerative colitis, all the ulcers, the loss of the haustra, and you get these kind of pseudopolyps that form in here. And here's pictures of that. Here's another chart. Excuse me. Another chart comparing Crohn's disease to ulcerative colitis. And I'm not going to go in depth with this, but you can see the differences, and you should definitely commit this stuff to memory. So this is a chart encompassing IBD and extraintestinal manifestations, some of which we've already discussed on a previous slide, but it's here for you to kind of look at. So moving on, we're going to talk about toxic megacolon, which is a complication, a severe complication in patients mainly with ulcerative colitis, although it can happen in Crohn's disease. It can also happen in patients with C. diff colitis. But it's striking when you see it, and you have to think about it and look out for it. So this is a plain film, and this is the colon. And it is huge. Look at these lumens, right? Look at the size of this colon. It's gigantic. And you think, like, there's no way that could fit in his stomach. Well, that's why it perforates. Essentially, it's a ticking time bomb for perforation. And so these patients generally have to have surgery and have it removed. So I'm going to show you some pictures. Warning, they are quite graphic and striking. So let's take a peek. Whoa. It's literally look like something out of a sci-fi novel. It's nuts, right? This is literally a person. That is the colon. And this is not exaggerated. This is not like some sort of trick. These are real pictures. This is how big the colon can get. And you can see how it can perforate inside the abdomen, because it just has no more room to grow, right? It's gigantic. So it can be lethal, and it's usually as a result of severe inflammatory bowel disease or colitis. Again, it can also be due to other things. Now, we said it says 2% here. I have anywhere from 2 to 5% of cases of ulcerative colitis, so it's not that common, but we have to kind of keep our eye out for it, especially in severe ulcerative colitis. And severe bloody diarrhea is the most common presenting symptom, and this is kind of a hard and fast rule. Essentially, if you have colonic dilatation more than 6 centimeters, that with signs of toxicity, that is diagnostic of toxic megacolon. So you can see here, this is 12 centimeters. So even if it's more than half of that, that's abnormal. It can affect all ages, usually with severe bloody diarrhea, we mentioned, and abdominal distension. Look at that. It just doesn't have anywhere to grow. Have to talk about IBD, potential recent antibiotic use, chemotherapy, antimotility, physical exam, usually a toxic appearance, hence the toxic in megacolon, and it really is a megacolon, it's gigantic. They're usually kind of out of it. They got this altered sensorium, fever, kind of out of it, peritoneal signs plus or minus. Again, we mentioned for diagnosis purposes, we should see evidence of colonic dilatation greater than 6 centimeters. We also plus at least 3 of the following. So fever, heart rate, greater than 120, neutrophilic leukocytosis or anemia. Remember, this is kind of the toxic appearance. And 1 of the following. So dehydration, ultrasensorium, electrolyte disorders, or hypotension. How do we diagnose it? Well, nowadays we tend to get CTs just as quickly or almost as quickly as we can plain abdominal films. So we usually use CTs to help make the diagnosis, especially in those that might require immediate surgery. And then, excuse me. We also use abdominal plain films. They're quick and they can show that colonic dilatation pretty quickly. Treatment. We got to get down the inflammation. We got to figure out what the cause is of the toxic megacolon. Essentially what it is a lack of motility and tone within the colon. It just kind of balloons up. We want to decrease the likelihood of perforation. Supportive and medical, and then surgery about 50-50. There's still some controversy regarding the timing of surgery, like when to elect to do surgery. So some of the supportive therapy that we do, I mean, this is like ICU admission. They're toxic, so you get routine labs, abdominal radiographs. They usually have to have some version of blood products, IV fluids, resuscitation measures, complete bowel rest, sometimes NG tube decompressions, broad spectrum antibiotics, and other things to help with prophylaxis. I also want to discontinue any type of opiates or anticholinergics. And really, like I said, you want to target the underlying disorder. So if it's C. diff, you want to target C. diff with the antibiotics. If it's ulcerative colitis, then we need to treat the severe ulcerative colitis to get this better. Like we said, a 50-50 shot of getting surgery. If there's evidence of perforation, necrosis, ischemia, essentially like an intra-abdominal compartment syndrome, you got to have surgery. And here's another picture. Look, this is the size of the hand, and that's the size of the colon. It's gigantic. All right, well, this would be a good time to take a break. We've been at it for about an hour. We have essentially colon cancer, colorectal cancer, and polyps to go. So take a quick break and then come back and we'll make it through the rest of this lecture. All right, next up we're going to talk about colorectal cancer. And it's the second leading cause of death due to malignancy in the United States. So that's pretty striking, right? Because of that reason, and also because of the amount of people that are susceptible to getting it, we have screening measures for colorectal cancer. It's thought that most of the colorectal cancers arise from adenomas, so abnormal growths within the within the colon, and from that tends to become a malignant transformation of an adenomatous polyp. The risk factors for developing colon cancer are going to be age. So you see a sharp increase in incidence after 45, and then almost all cases occur in patients over the age of 50. There are some more rare cases that happen less than that, and in that case, all your first-degree family members should be heightened concerned and heightened risk for developing colon cancer. Like I mentioned, a family history of neoplasia, whether it's general neoplasia or colorectal cancer or polyps, these have increased risk of colon cancer. So one first-degree family member have increased risk 2 times that of the general population. And then almost 4 times if the patient was less than 45 when they were diagnosed. If you have 2 first-degree relatives, a 4-fold increase or 20 to 30% lifetime risk. That's pretty high risk. So these patients, obviously the screening and surveillance measures are more aggressive. Other risk factors: smoking, consumption of red and processed meats, alcohol intake, diabetes, physical activity or obesity, and a history of IBD, especially ulcerative colitis. And here you go. Here's some of the patients that are more high risk. There's also an additional risk factor, which are the major polyposis syndromes, these are some of them here. We will cover this in the polyp section a little bit later. What are the signs and symptoms of colorectal cancer? Well, we hope that we will catch these cases of colorectal cancer before they develop, hence eliminating the need to look for signs and symptoms. However, we don't live in a perfect world, and there are plenty of people out there that are not doing routine screening and surveillance for colon cancer. And in that case, we have to keep an eye out for the signs and symptoms. It really depends on the location of the tumor. Remember, we have a colon that wraps around this way, and we have a cecum here, right? So we have all of this area that we have to consider. We have the cecum, the distal or right side of the colon, the left side of the colon, and it's generally divided about right here. So let's talk about right-sided tumors. So obstruction is unusual, so there's a larger luminal diameter here on the right side. Cecum is obviously the largest. It's the little balloon in the first part of the large intestine. And so a lot of these large tumors grow undetected on the right side because there's just more room for them to grow without wreaking havoc. So findings that you find: blood in the stool, iron deficiency anemia, and melena. Also have a change in bowel habit, but that's rather uncommon because remember, it's happening on this side of the colon. Anemia, weakness, and right lower quadrant mass are usually present or occasionally present. Left-sided tumor, so on this side here, we have a smaller luminal diameter, so you see more signs of obstruction. And remember that colon cancer is the #1 cause of large intestine obstruction. You also see more often a change in bowel habits, because if you have a mass that's kind of sticking out, blocking a lot of this, where the stool is being formed and pushed out, you can tend to get these pencil stools. And that's usually if it's kind of circumferential and you only have a very small area for the stool to pass through, they become thinner and pencil-like. You also see hematochezia more common because the blood is fresh coming from the left side. Now, as far as rectal, because we're talking about colorectal, so it's not just the colon, it's the rectum itself. Hematochezia is definitely most common, as well as tenesmus, and this feeling of incomplete evacuation. So if you have a mass where the stool is, it can feel to patients like they don't completely eliminate the stool. So clinical findings, again, here's kind of the same picture I just drew you kind of crudely. Here's the division between the right and the left. You should kind of know the differences between the two. You should know that right-sided colon cancer is more common in women, and left-sided is more common in men. And then here's some other things that can be associated with it. Adenocarcinomas grow slowly, so they can be present for several years before the symptoms appear, and that is why it's so crucial to screen these patients before there's problems. And again, we mentioned the right-sided and left-sided, also rectal cancer, so similar to the previous slide. Physical examinations is usually normal except for an advanced disease. Laboratory findings, so we're going to do a little bit of a workup. We do a CBC looking for anemia. CMP, we're looking at liver, serum alk phos, which is raises suspicion of metastatic disease. We also use CEA. It should be kind of measured at baseline with colon cancer, although it is not a screening tool. And then after, if colon cancer is found and afterwards, CEA levels should go down to normal, and that's how we one of the ways that we do surveillance on patients to make sure that they stay down. So if they start raising back up, it might mean that there's persistent disease or warrant further evaluation. Colonoscopy, this is the best diagnostic test for colorectal cancer. It is the required diagnostic procedure in patients with suggestive of colon cancer or some sort of suspicion, right? You should also consider upper endoscopy in patients with iron deficiency anemia. And essentially you get the biopsies and you send them for pathologic confirmation, because remember, we're taking these polyps out or masses, and so we don't really know whether they're benign or malignant. We can have an idea, but we won't really know until we get the biopsy and run it through pathologic confirmation. Imaging, once we have the diagnosis of colon cancer or the presumed diagnosis of colon cancer, we tend to do chest, abdomen, pelvic CTs to look for preoperative staging and looking for metastases. Here's the staging for colon cancer. We use the TNM system, which is tumor, node, and metastases. And obviously the more advanced stages are associated with worse outcomes. It also helps give patients kind of this idea of their long-term survival, and also helps providers decide whether they are candidates for non-adjuvant or neoadjuvant therapy. So surgery is the only curative treatment for colorectal cancer. If there are regional lymphatics that are involved, that have to be removed as well. Like we said, CEA levels should be obtained before the surgery, and then there are some guidelines for continuing doing CEAs after surgical resection. In some cases, chemotherapy is used. The radiation therapy is only used in rectal cancer, not in colon cancer. However, the use of chemotherapy radiation is kind of beyond the scope of our lecture that we're doing. Follow-up after the surgery is done and the colon cancer is removed, we do stool guaiac testing, annual CTs, and chest x-rays, colonoscopies at 1 year and then every 3 years if it's normal, and then CEA. So we usually get CEAs every 3 to 6 months, and we're looking for any elevations. If a patient is going to have a recurrence of colorectal cancer, it's usually within the first 3 years. And the 5-year survival rate really depends on the stage of the disease. Stage 1, a 5-year survival rate is about 90%, so it's highly preventable if we can catch it early enough. Whereas, stage 4 is all the way up to 5 to 7% 5-year survival rate. Now, it is known that rectal cancer alone has a higher recurrence rate and a lower 5-year survival rate. And a treatment of rectal cancer is a little bit different than colorectal cancer. So you can do some more localized diagnostic tools such as this endorectal ultrasounds and MRIs. Screening. If you don't remember anything about colorectal cancer after this lecture, which we've been talking for over 70 minutes, so a lot of this might get kind of jumbled and you might have to go back and review it more and more often. But if you don't remember anything, remember this, okay? Remember how important screening is for colorectal cancer. It's a common disease. Remember, there's quite a few people that have it. And it is fatal in almost 50% of cases, and it's curable if you find it early on. So that is why it's so important, right? Because these start from little tiny polyps and work their way up to cancer, right? So we have to screen these patients. There is the USPSTF has given us pretty clear screening guidelines for patients. So colon cancer screening begins at age 45. Now, I don't know if any of you have ever had colonoscopies or anything like that. You might remember that the age used to be 50. And it just changed. It just changed in 2020. And it recently just became universally adopted as the age to start. Before it was the age of 50. So in an average risk patient, colon cancer screening begins at age 45. If the patient has more advanced risk, especially if they have one first-degree family member that has had colon cancer, you will begin screening either at age 40 or 10 years before the age of onset of the family member, whichever is earlier. As far as screening is concerned, DREs are not very good at detecting it. Only about 10% of tumors can be felt by digital rectal examination. Now, there are choices as to how to screen patients. I will say that the best screening tool is going to be colonoscopy. That is the best. There are different methods for screening. Average risk individuals, we said 45 years or older. There are all these things that we can do for screening purposes, and I'll go over them shortly. I believe on the next slide we'll talk about the difference in different kinds of testing that we can do. And again, like we mentioned here, if the patient has a family history, first degree relative, then we start either at 40 or 10 years earlier than the age at which the diagnosis was made. All right, so when we talk about screening, there are basically two main methods for screening for colorectal cancer. One is stool-based, and the other is endoscopic or radiographic imaging. So let's talk about the stool-based test first. Now, keep in mind that the only patients that qualify or should use stool-based testing are average risk patients. You should not use stool-based tests in those with increased risk of colon cancer. Fecal occult blood tests are done, although this is not necessarily considered first line. The FIT, or the fecal immunochemical test, is considered superior, and it's done yearly to every 2 years for screening purposes, starting at age 45. It's less invasive than a colonoscopy, and some patients just prefer to do this than have a procedure. Some patients are not able to tolerate procedure, so that's a suitable alternative. If you do have a positive test, then you have to do the colonoscopy anyway. Okay. Now there is a newer treatment or a newer screening tool out there. I'm sure you've seen the little Cologuard is like a little box that like walks around, right? Cologuard. It is a combination of the FIT that we saw here combined with fecal DNA. And it's better than the FIT alone. It's about 92% sensitivity compared to 73% for the FIT. And if it's positive, you still have to do a colonoscopy. So those are things you have to consider, especially from a patient expense perspective. Most insurances will only pay for one screening. So if you get this, it's quite more expensive than just the FIT alone. And it comes back positive, well, then you have to get the colonoscopy anyway. So sometimes insurance will give you a fit about covering two different screening tools. But It's just something to consider. Again, you can only use these in average risk patients. Now, endoscopic examination, colonoscopy is the best. It lets you examine the entire colon. You're looking, and it can be both diagnostic and therapeutic, meaning if you see a polyp, you can go and remove it and send it off, right? It is the best diagnostic test. It does have some kind of issues or things you have to consider. It is invasive. The patient has to be sedated to have the test done. Some patients can't tolerate that. You have to have a clean colon. And for any of you that have never had a colonoscopy before, the worst part of the whole thing is the prep. And the prep, they are better nowadays. We have some better preps like movie preps and things like that are smaller volume, and they don't taste as bad. They're not as horrible, but it's still brutal. I mean, you have to essentially clean out your entire colon of stool, and that can be grueling, to say the least. The last but not least, one of the things that is limiting with colonoscopy is the skill of the operator. Most GI doctors, I mean, this is routine, bread and butter procedure that they do. So they are really good at what they do. But in, certain providers, I mean, it is only as good as the person doing the colonoscopy. An alternative is a flexible sigmoidoscopy. This only goes up into the sigmoid colon, and part of the distal colon. The chief disadvantage of screening is that it still requires some bowel cleansing, such as enemas and things like that. It is kind of uncomfortable because usually they don't use IV sedation, and it doesn't see any of the other part of the colon, right? It misses most of the colon, although most polyps are found in this area. Again, any patient that finds a polyp requires the colonoscopy. Everything leads back to the colonoscopy. Every abnormal leads back to colonoscopy. One of the newer tools for screening that we have is a CT colonography. And this essentially uses a CT to kind of reconstruct or create a virtual colonoscopy. It does require a similar bowel cleansing as a colonoscopy. And they also have to have air kind of inflated into the colon through a rectal tube, which is kind of uncomfortable. But it's performed pretty rapidly, and you don't need sedation or IV contrast, so it can be used in patients that can't tolerate colonoscopy. Again, if you have a 10 millimeter or larger polyp, you should be referred for colonoscopy with polypectomy. Remember, because you can't remove the polyps on a CT colonography. Other things that we can use, capsule colonoscopy and barium enema, but we really don't use those very often. Here's a money slide. It is an older slide from Up to Date. I don't believe it's actually on Up to Date anymore because there's been so many changes since it was on there, but I have modified it to kind of fit our needs because I like algorithms. So does the patient have symptoms? If yes, we have to do diagnostic studies that we talked about earlier. If they don't have any symptoms, then we have to consider their risk. Are they increased or average? Now, increased risk could be a personal history of, say, IBD, or it could be a family history, right? A family history of either adenomatous polyps or colon cancer, or one of the genetic syndromes that we'll talk about shortly. Now, over here in the average risk, similar to what we talked about earlier. If they're less than 45 years, you don't screen patients with average risk. If they are greater than 45, then here's those options that we just talked about. If they're positive, we have to go for the colonoscopy, unless we do the colonoscopy. Okay? And then here's those guidelines for patients that have these increased risk factors, especially first-degree relatives. Colorectal cancer does metastasize. You can have direct extension through the bowel wall, and that can invade other organs within the abdominal cavity. You can have hematogenous spread. Liver is the most common site of distant spread. You can also have a spread through the Batson's plexus. Remember the vertebral venous plexus up to the lungs. You can get regional lymph node and then transperitoneal or intraluminal. And about 20% of patients have distant metastatic disease at presentation, hence why it is so important to screen before it gets bad, right? All right, so we talked about colorectal cancer, but we can't talk about colorectal cancer without talking about colon polyps, because colon polyps they can be benign, but they can also be precursors to cancer. What is a polyp? Well, it's a little mass or lesion that protrudes into the intestinal lumen. So we have the intestinal lumen like this, and the polyp comes out into there. And there's different kinds of polyps. I'll show you some different pictures of them. It can be isolated, so you can have isolated polyps throughout, or it can be part of one of the inherited polyposis syndromes, and those have a very high malignant potential. We will talk about those separately. The majority of the polyps are found in the rectosigmoid region, which is why we can use flexible sigmoidoscopy as a screening tool. Again, most patients are asymptomatic, and if they do have symptoms, bleeding is the most common symptom. There are 4 major pathologic groups. I know this is pathology, but it's good to kind of wrap your mind around it. We have the adenomatous polyps. These are the ones that tend to turn into adenocarcinoma, right? We have tubular, tubulivillus, and villus, and we'll talk about those separately. We also have the serrated polyps, the most common of which is hyperplastic, which is a benign polyp. And you also have the sessile serrated polyps, which can also be precursors to cancer. You have some juvenile hamartomas and inflammatory polyps, which we won't really talk about too much. And then some of the submucosal lesions listed here, which we also won't talk about too much. How do we treat polyps? Well, we have to remove them and send them for pathological evaluation. Polyps can sometimes, all of these different polyps, you can't always tell by just looking at them. You have to actually send them off for pathology. And most of the polyps removed in colonoscopy are going to be adenomatous. These are benign, however, they do have potential to progress into the adenocarcinomas that we know as the most common type of colorectal cancer. Let's talk about non-neoplastic polyps first. These are benign, they don't have any malignant potential. The ones that we see the most are hyperplastic polyps. When I worked in the GI clinic, one of my responsibilities was going through pathology reports from patients that had screening colonoscopies, and it was my duty to look for these findings of these polyps, making sure that they were hyperplastic or what type of polyps they were, and then have the patient follow up accordingly. Again, the most common type of benign polyp is going to be the hyperplastic polyp. Really, they don't require any specific therapy. You really just remove them and send them off for pathology. There's also some juvenile polyps that we'll mention later on, and pseudopolyps, which we said were associated with ulcerative colitis, that get removed. Adenomatous polyps, let's talk about those next. These are benign, however, they have significant malignant potential. They are essentially the precursors to adenocarcinoma. And we said there are 3 types, and the further down they go, the worse off they are, the greater malignancy. Okay, so the first that we see is the tubular. Tubular is the most common type of adenomatous polyp, and it has the least amount of risk of malignancy. Kind of moving up the platform, we have this tubulovillus, which has an intermediate risk of malignancy. And last but not least, we have this villus. And the way I like to think of it is villus sounds like a villain, right? And villains are bad. So this is the worst type of adenomatous polyp that you can have, has the highest risk for malignancy. Other things can help you determine malignant potential, meaning by looking at it both grossly with the colonoscopy and with the pathological specimen. These things can help you kind of determine the malignant potential, the size. So the larger the polyp, the greater the malignant potential. What histologic type it is, one of these 3. How much atypia there is of the cells, like is there changing of the cells? And then also having the shape of it can help you determine. So sessile is flat, those are more likely to be malignant versus pedunculated, which are on a stalk. And I do have a picture of that I will show you. 3 types of serrated. So serrated polyps we don't talk about as much. Adenomatous polyps are way more common, but we do see some serrated polyps. Again, we mentioned hyperplastic polyps is non-malignant. There is also sessile serrated and traditional serrated adenomas, and these can harbor an increased risk of colorectal cancer. So surveillance colonoscopy, when do we do those? So we find a polyp on a colonoscopy, whether it's screening or otherwise, then we have a different set of surveillance protocols. So have to remember the difference between screening and surveillance. So screening is the first time we look for someone, and if it's normal and we repeat it 10 years later, the colonoscopy, then that's a repeat screening because we have never found anything. We have never found anything. It's either the first time we're looking or we're looking again after a normal one. Surveillance, on the other hand, is done after you find something, whether it is polyps or colon cancer. Surveillance means we're going to take a second look, and surveillance usually means more aggressive looking for these polyps and precursors for cancer. And these are the recommended surveillance guidelines for post-polypectomy. So it depends how many you have, what types they are, and that determines how often you have colonoscopies after finding them the first time. I don't expect you to memorize this, but I think it is important to know that the surveillance is different. And here's some pictures of polyps. We mentioned earlier that sessile polyps, the shape of them, tends to be more malignant, and that is when it kind of hugs the lining, so it's pretty flat. Whereas pedunculated means on a stalk. These are less malignant. This little stalk is what makes it pedunculated. And then I'm going to show you just a few pictures of some polyps, and you'll pretty much come to find that it's hard to differentiate them grossly. And then, of course, you can tell histopathologically. However, I don't expect you to know that. So here's some hyperplastic polyps. Don't look like too much, but take them, send them off for pathology. Remember, those are benign. Tubular adenomas, again, those are also benign. And you can't really tell the difference between a tubular adenoma and a hyperplastic polyp. Remember, tubular adenomas are the least malignant potential of all 3 different types of adenomatous polyps. The second is the tubulovillous adenoma, which has increased risk of malignant potential. And then the worst, which I have our little villain here, is the villous adenoma. This has the highest risk of malignant potential. Okay. Now, going back to colorectal cancer and the polyps, major polyposis syndromes, I'm going to mention them, but I am not going to go into depth on these because most of the time with these it's more of a recognition than knowing every single thing about it. The most common thing that we see is familial adenomatous polyposis, or FAP. Most of the time patients know that their family has this. It is an autosomal dominant disease, and these patients don't just have hundreds of polyps, they have blankets of polyps. When you do a colonoscopy, it is literally everywhere. And as you can imagine, you're not going to be able to remove all of these with snares in an endoscopy. These patients exclusively have to have colectomies, and they're prophylactic because there is 100% risk of developing colorectal cancer in the 3rd or 4th decade of life, meaning 100% of FAP cases will become colorectal cancer. So these patients have colectomies. They have their entire colon removed because of that risk. Some variants of FAP are Gardner syndrome. These tend to have kind of osteomas, bony abnormalities, dental and soft tissue tumors. And then there's Charcot syndrome, which is usually plus some sort of neurological issues. So FAP plus neurological issues. This one's usually skin, and this one's usually neuro. There are other polyposis syndromes. One is called Peutz-Jeghers. This is also an autosomal dominant. It's pretty rare disorder. These patients tend to have hamartomas, which are benign and have a very low malignant potential. They also get these melanotic macules, these little kind of look like freckles, especially around the lips and the face genitalia. And if you see that, you should think Peutz-Jeghers. They can have some incidents, slightly increased carcinomas like stomach, ovary, breast, testicle, lung, and then they can have some intussusception and GI bleeding. If you're curious, I would definitely click here and check out this young man's experience, and he kind of talks about what he's been through as a PJ patient. So it might be worth your while to click that. It's a short YouTube video. Some other ones, familial juvenile polyposis, and also this hereditary non-polyposis, CRC, which is also known as Lynch syndrome. And that's about as much depth as I'm going to go in on these. They're really rare and don't see them too often on our tests. Last but not least, I just wanted to show you quickly the different types of colectomies. These are the things that we do usually when we find tumors, depending on where the tumor is located. So in this case, there's a left hemicolectomy with anastomosis. There's also a right hemicolectomy with an ileocholic anastomosis. And then abdominal perineal resection. When you have a tumor kind of in the rectum area, you resect that, you essentially close up the skin of the anus, and you create a colostomy, and you have a bag for these type of patients. So not so important always to know who gets what. For colon cancer, I mean, you're going to resect the area. That's the curative thing. But I just wanted to show you some illustrations of that. And that is it. That was a very long lecture, and I understand that it was long. Thank you for pushing through. Some of these are some of the more complicated colonic disorders, especially IBD and Crohn's. I think those are probably some of the more complicated GI disorders. And so you might have to go back and spend a little more time on that to make sure it sticks up in your brain. Other than that, make sure you know screening guidelines for colon cancer. I can guarantee you I will have some test questions on that. And that'll be it for today's lecture, so I will see you next time.